Okay. Okay, all right. Good evening, everyone. My name is Cherise Spencer. I'm Director of Community Engagement at the Howard University Cancer Center, and it is my pleasure to welcome you to our program tonight for our sisters, a conversation about breast cancer. We first want to apologize. We did have some technical challenges at the very beginning. However, you will see that a new link has been posted on the previous link to be able to connect to the YouTube page. And so at the end of the night, we are going to have such a wonderful presentation that we'll look back at all of this and won't even remember the challenges that we had up front. I first want to take a moment to acknowledge our sponsors for this event, the Charmettes Incorporated, and their president, Mrs. Catherine Lewis, who is joining us on live stream, and the Georgiana Thomas Grand Chapter, Order of the Eastern Star, and their Grand Worthy Matron, Miss Eunice Dingle, who is joining us here tonight. Both of these organizations have been longtime supporters of the Howard University Cancer Center, and we are very grateful for their ongoing support. We'd also like to welcome our moderator, veteran news anchor, Ms. Andrea Roane, and thank her for her continued support of the Howard University Cancer Center. And last but certainly not least, we would like to thank our Peak Power panel. It is truly a pleasure not only to work at the Howard University Cancer Center, but to work with this incredible group of women. Despite their busy schedules, with the demands of their work, families, and other commitments, they always make time in their schedules to be available for events such as these. Whether it is getting up early on a Saturday morning by 6 a.m., actually they have to be here at 6 a.m. to do clinical breast exams for our free breast cancer screening program, are doing digital rectal exams at the convention center. Do you remember that, Dr. Dunmore? For several hours during Congressional Black Caucus and the NBC4 Health and Fitness Expo, are rushing to a church to give a presentation after a long day of seeing patients, or even traveling to Africa to provide much needed services for the women. They are always available to support our programs. We are truly blessed and grateful for everything that they do tonight. And now I'd like to introduce, we consider you the latest addition to our dynamic team of women, Howard University Hospital CEO, Anita Jenkins.
Good afternoon, everyone, and welcome. Again, my name is Anita Jenkins. I'm the CEO of Howard University Hospital, part of the distinguished Howard University and Adventist healthcare family. It's truly an honor for me to be a part of this wonderful event, speaking on behalf of Howard University's Cancer Center. So before we start, I want to take a moment to thank and acknowledge again our moderator, veteran television news anchor, and breast cancer advocate, Mrs. Andrea Roane. Andrea has been a staple in the greater Washington, D.C. community for many years. She has used her platform to raise unparalleled awareness on the wide range of healthcare-related issues and concerns that shape our region. Thank you for being a part of this conversation today on breast cancer. I'd also like to thank again our esteemed Pink Power panel of healthcare experts, as well as respected physicians sharing our knowledge and insight, speaking of volumes about our combined determination, commitment, and investment to combat breast cancer and improve healthcare in this community. For our sisters, a conversation about breast cancer is a topic that is near and dear to my heart. Sadly, but not forgotten, I lost a very dear friend, my dear friend and my personal physician, to breast cancer 3 years ago. I have not forgotten that we have the opportunity to change lives and save lives with information and care. Too many people know what it's like to lose someone to this terrible disease or watch a loved one go through the uncomfortable treatments and surgeries necessary to try and defeat it. And too many people have had to deal with the uncertainty, and fears that accompanies it. So each year, breast cancer impacts the lives of millions of women and men in their families. Unfortunately, the statistics for breast cancer are startling. The American Cancer Society reports that more than 400,000 women in the United States are diagnosed with breast cancer every year. That 1 in 8 women will develop breast cancer in their lifetime. How many people on this call? 1, 2, 3, 4, 5, 6, 7, 8. 1, 2, 3, 4, 5, 6, 7, 8. And that's why we're here. In the communities that we serve, there are a number of social economic factors that hinder minorities from receiving the proper care. And that's why we're here. Disparities point directly to the need for better breast cancer awareness, education, access, as well as improved information for our community. As healthcare professionals, we are responsible, I am responsible, for administering care to those who are impacted by this disease. And with that, we say thank you for coming, welcome, and be informed. Thank you.
Hello again, I'm Andrea, Roane. Good evening and welcome to everyone. Thank you for joining us for what we know will be an informative and engaging conversation. And it's a conversation we want you to be a part of. So please put your questions in the comments section, and Ms. Mariah Tate from the Howard University Student Society of OBGYN will be monitoring the comments and will respond to as many as we can throughout the evening. It is my pleasure now to introduce the Pink Power panel. They are powerful women, all dynamic and associated with the Howard University Hospital. It is my pleasure to introduce Dr. Kelly Bolden. Dr. Bolden is double board certified plastic surgeon. She has devoted much of her career to providing advanced surgical techniques in underserved and underrepresented communities, both domestically and internationally. Through personal experiences in the operating room, as well as being one of the very few Black female plastic surgeons in the country, Dr. Bolden motivates and provides leadership, insights for team building, problem solving, and career fulfillment. Dr. Jacquelyn Dunmore Griffith. Dr. Dunmore Griffith is a board certified radiation oncologist specializing in brachytherapy for breast, gynecologic, and prostate cancers. Dr. Dunmore has conducted research on improving outcomes of radiation therapy. Her research also includes examining the effects of physical activity on breast cancer risk and exploring outcomes and preferences for treatment in older women. Dr. Lori L. Wilson. Dr. Wilson is a cancer surgeon and researcher who currently is Division Chief of Surgical Oncology at Howard University Hospital and Associate Dean of Faculty Development and Diversity at Howard University College of Medicine. She works closely with a multidisciplinary cancer team to provide treatments individually tailored for each patient. She is a physician scientist well known for her work in translational research, community engagement, and health disparities. Her many publications have focused on shining the light on the causes for disparities in her patients, as well as establishing community partnerships to develop health and wellness strategies for those she serves. And Dr. Sara Horton. Dr. Horton is a board-certified medical oncologist, and she currently serves as a medical oncologist for the Howard University Cancer Center, Transdisciplinary Breast Cancer Clinic, and is a part-time faculty associate professor of medicine. She has worked for the FDA Office of Hematology and Oncology Products as a medical officer in the breast cancer division, reviewing all phases of oncology drug clinical trials. Dr. Horton has had over 20 years of caring for cancer patients. She just told me how much she really likes the one-on-one contact with her patients, as do all of these professionals and Pink Power panel members are engaged in. And she currently continues her work with Howard University Cancer Center, as well as consulting on oncology quality measures and utilization and review. It is a powerful panel, and panel, thank you for being here. I know it took a lot to get here. Traffic was a bear, but they made it. We have divided our program into different segments, and the first one is just the basics, Breast Cancer 101. There's a song in The Sound of Music, you know, the do, re, mi, and it tells us let's start at the very beginning. It's a fine place to start. Well, that's where we want to start. In case we have some participants who've heard of breast cancer, but may not be entirely certain what it is, Dr. Wilson, will turn to you first and have you explain to us what is breast cancer, what happens, a person is born healthy, and something changes in their body that brings about a diagnosis of breast cancer. What's going on?
Thank you very much for the opportunity first to be here and to address this. One of the things that I think is important to understand about breast cancer is that it comes out of an understanding of breast cells. Typically, we think of breast cancer as breast cells that go awry. They lose their ability to control themselves. And so what happens is they actually grow out of control and they lose the requirements that we have to stop, to listen to what's happening around it, and to then, when things don't happen well, they spread to other parts, potentially, of the body. The breast is where it starts. It can potentially go to other parts of the body, like the lymph nodes, and the lymph nodes are sort of the gatekeepers from keeping cells from going other places. And then when it goes past that, then it may go to distant sites, and that's what we call metastasis. And metastasis means it could potentially go to the lungs, the liver, the brain, the bone. All of those things working together, it's important to know about breast cancer leading to stages of breast cancer, stage 0 to stage 4, stage 4 being metastatic, stage 0 being non-invasive.
Dr. Bolden, Dr. Wilson was talking about stages 0 to 4. What's the meaning of the stages as far as treatment and diagnosis is concerned?
Oh gosh, that might be a better question for one of y'all to answer than me.
Well, whoever thinks they can answer that, that's fine.
So
Staging, how important is knowing what a stage is and what the impact is when it comes to treatment and diagnosis?
As Dr. Wilson mentioned, all cancers are staged. And staging basically means how far the cancer has grown or how large it's grown. And the closer you are to 0 or 1, the more likely we can treat it and cure it and remove it so that it never comes back. Stage 4, as Dr. Wilson says, means that the cancer cells have spread from where it started and gone to other places in the body. And we call that metastatic, stage 4. And usually, because it's spread outside of where it started, there are times, the majority of times, we can't get rid of it all, but we can use treatments to keep it at bay. And so there's also prognosis, meaning how likely you are to have complications or to even die from the cancer based on your stage. And the closer you are, so stage 0, stage 1, and stage 2 are all stages where we can do treatments that can potentially cure it and take care of it so it never comes back. The higher the stage, though, the higher the chance that you have that it may come back in the future. So for instance, if a woman has a stage 1 breast cancer, that means they found it at a small size. It has not gone to the lymph node, so it's just in the breast. We can do treatments to remove it, maybe give some type of treatment for a period of time afterwards, and they can have over a 90% chance, meaning most women will never hear about that breast cancer again. If you're stage 3 breast cancer, that means that they found the cancer a little larger size. It may have gone to the lymph nodes as well. Just tells us it's been there a little longer. It's going to take a little bit more to try to keep that from coming back. And after you treat it, it may be gone, but over the next 5 to 10 years, it may be that 50% or half the women who had that will have it come back.
How many women are diagnosed with breast cancer each year? Anita was talking about counting out 1, 2, 3, 4, 5, 6, 7, 8. What are we talking about?
Right, so that number 1 in 8 is a lifetime risk of women. So we've pretty much all heard that in your lifetime you have 13% chance of developing breast cancer. They estimate that this year that there will be about 285,000 women diagnosed with breast cancer.
Is that number coming down, or it seems to be the same? We've been talking about 240, 250,000. What's going on? It doesn't seem to get any better with all that we're doing.
Well, we're talking about diagnosis.
And I don't want to put it all on Dr. Horton. Anybody who wants to jump in.
You know, if I get started, I just but you all can go ahead.
Go ahead. Yeah, you started. Go ahead.
Okay. I'll make it short. So, so the number, yes. So different things affect the number of how many women are diagnosed. Sometimes it's good. So when we developed screening, when mammograms in the 90s, we picked up a lot more cancers than we had. It was a good thing because a lot of them were earlier and they were treatable and the women were cured. Around 2000, we learned that hormone therapy can increase breast cancer. So we stopped, and you started to see a decline in the incidence of breast cancers. It's picked up a little bit now. I think it's gone up maybe 0.5% from last year. It's very small, but we're starting to see now that we're picking up more breast cancer.
So it's more of a reporting thing than the numbers changing one way or the other, fluctuating.
Right.
But we do have some disturbing new numbers about 20-year-olds and 30-year-olds being diagnosed at stage 4 cancer, and this is something that just came out with aggressive stage 4 cancers. What can you tell us about that, and why might that be happening? Whoever wants to jump in, jump in.
Before we move on, I want to jump in that the 280,000 that we were talking about really are all comers. And so different ethnicities have different rates of breast cancer. When we think about women that reflect my ethnicity, it's probably closer to 40,000 women per year. One of the things that we do know is that there are some African American, Afro-Caribbean, and African that may make them more likely to have more aggressive breast cancers. And we oftentimes talk about that at the molecular level. We talk about triple negative breast cancers. We also are finding that those breast cancers may be diagnosed earlier, they may be diagnosed younger, and they may be more aggressive at the time of diagnosis. And that may be some of the impact that we're beginning to see in younger ages, and may begin to give some of the answers. The difficult part, talk about biology, we talk about the psychosocial. So many things sort of play a role, and now we're realizing that one thing doesn't tell us the answer. We have to really get together and think about all of these things and figure out how to fix them to make these things lesser of a problem for women that we especially are drawn to and that we practice.
And another thing with younger women being diagnosed with more or later stage disease, because people don't think of a young person having breast cancer. So oftentimes you'll have young women who present with a breast mass or breast pain or discomfort. They're too young to have had a mammogram, and when they see their physicians, most physicians again don't think about breast cancer in a 20-year-old. So there may be a delay in diagnoses, and that often can cause you being diagnosed at a later stage.
How do you change that in the medical community to even consider breast cancer as being a risk factor for a younger woman?
It's teams like this, right? It's teams that are reflective of, we're blessed to serve a community that is reflective ethnically of who we are. Probably about 90+ % of our patients are from our community. So we have this preponderance of information that we get, not only because we're researchers and that's what we do, but we see it all day long. We see it and we are comfortable with it. And with that comes information. I think one of the things that we haven't also discussed is COVID.
Yes, we'd like to get to that right now. What's the impact of COVID?
So you know,
Perfect transition.
I just think
What's it like being Black, breast cancer, and in the midst of a pandemic?
Yeah.
You know, it has been tough because COVID has, and not all, I never want to blame the patient, because some of the time the centers were just closed
Right,
altogether.
right.
Women did not have the opportunities to screen. Also, those screening opportunities that they have were scary. You know, that meant you had to come to a facility that had higher risk of catching COVID. And I think in the very beginning, when we didn't have as much information, that many of the patients that we saw, they didn't want to come into the fray. And now we're starting to see those, and it was predicted, but we're starting to see those increases in numbers for those patients. We're starting to see, and I'm definitely starting to see women with later stage breast cancers, and I'm sure you all are too, that I probably haven't seen as many in the last 5 to 10 years as I'm really seeing right now.
Yeah. And I think COVID basically kind of magnified a lot of the inequities that we see in medicine in general for that exact same reason. We know that minorities were disproportionately affected by COVID. And so because of that, a lot of people really, truly, genuinely feared coming to the hospital, genuinely feared coming to their appointments. So even though we'd reopened our clinics, we had a lot of people that would no-show and things like that, not because they didn't want to receive their care, but they were genuinely fearful. And I think that's something that we can all understand. And so now is one of the reasons that we're doing this is to make sure that people know, come back, come get your mammograms, come get evaluated, you know, see one of us, see your primary care doctor or whoever you need to see so that we can ensure that you're getting treated earlier, because like Dr. Horton said, the earlier we can detect it, the better, the more treatment options there are.
So the message is get back on the books.
Yes.
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 We need to be
It's
back
time.
on the books.
Yes.
That's the one thing we
Absolutely.
want is the takeaway from this event this evening.
Absolutely.
Get back on the books. It's important to be screened. What about the vaccines for COVID when it comes to breast cancer patients? Are they safe? Are they problems for persons with breast cancer or any other autoimmune disease or compromise? Yes.
So the COVID vaccine is safe for breast cancer patients or other cancer patients too. Of course, you would need to have that discussion with your doctor, but the COVID vaccine is not a live vaccine, all right? So if you're immunocompromised, it's even more important for you to get it, because if you contract COVID, you're going to be sicker and stand a greater chance of being hospitalized and even dying from the disease. So breast cancer patients, yes, get the vaccine, get the booster, because you fall into that immunocompromised condition. Not all vaccines should be given to cancer patients, and that's again another question that you have to have with your provider, because some vaccines are live vaccines, and in immunocompromised people we don't necessarily want to give them a live vaccine. But the COVID vaccine is very safe to get, and breast cancer patients, anyone out there listening, anyone out there, whether you have cancer or not, we strongly encourage you to get the vaccine.
Absolutely. And you
One
said
of
the
the thing-
booster is also recommended.
booster.
Yes, the booster is
Absolutely.
definitely recommended.
And then I'll just speak a little bit on some of the things that you might see after you have your vaccine. Sometimes in the arm, the underarm, you might get enlarged lymph nodes, and so that may be something that that radiologists may see after having the vaccine.
Yeah.
But we know that those oftentimes are just reactions to what the body is supposed to do. The lymph nodes are in part of, over time, they will get better, and it usually is about a
Couple
6 week at most time frame.
Right, and they recommend if you're getting your mammogram, your screening mammogram, that you do that at least a few weeks outside of it.
Exactly.
Yeah, because
right.
what's happening now when patients are having their mammograms within the time frame and they have these lymph nodes, it's confusing for the radiologist when they're reading because they can't necessarily tell it's an enlarged lymph node, so it's meeting the criteria of a malignant or a cancerous lymph node, but in actuality it's not. So oftentimes if you've had it, they're going to have you come back and repeat a study or an additional study just to make sure.
All right, we're jumping around a little. We're going to go from inequities and come back to that to screening. What screening tests are done for breast cancer?
So typically for breast cancer, it's either a physical examination or it's some type of radiology study. The standard radiology study is what we call a mammogram, all right? So a mammogram is where you take x-rays and you look at the breast tissue. Anyone who's had a mammogram knows it's probably not the most comfortable, and Dr. Wilson will address that for you, but that is still the standard of care, a mammogram. Depending on the density of your breast or the age you are or your family history or risk factors, you may actually be recommended to have an MRI. Now, an MRI doesn't use x-rays. It uses a different type of wave, so it looks at the breast tissue and it can give you more information, but it's still not the standard of care. The standard of care is the mammogram. Also, when I said it's physical examination or radiology, which is the mammogram, we recommend that you do both. The physical examination is typically either a self-breast exam, and Andrea, you know very well with Buddy Check 9, right? Yeah. That was our motto for years and years, that one, the self-breast exam, the clinical breast exam, and then having a mammogram, if you miss something on one, because everything's not going to show up on an exam. If it's very small, you may not feel it, but hopefully the mammogram will pick it up. And sometimes if you have an abnormal mammogram, a screening mammogram, they're going to bring you back for additional mammographic images, what we call a diagnostic mammogram, where they look at the breast from different angles. They may
there actually is some new methodologies that are being utilized with the current mammogram machines. As you all know, the mammograms usually are two flat plates that fit together, and the whole way of doing it is about compression. Right?
Yes.
Trying to get the breast tissue as flat as possible, so you can see through it better. There have been several companies out there that actually have worked on changing the shape of that paddle. We use Hologic here at Howard University Hospital, and they are actually one of the companies that partnered to look at the best methods for improving. And so they have a smart paddle that you can actually ask for and just let them know that you have a very tender breast. And they can use that to follow the curve of the breast. You may ask, why did it take so long? Yeah. But nonetheless, we're improving. And so that is one of the ways. There are new technologies out there that are being developed as well that combine the current technology that we have with different methods of laying flat, and also different technologies within the machine to better look through the tissue. That's coming down the pike. But right now what we have and what's being instituted is usually this new paddle that is softening the compression.
After you've gone through the compression and you're sitting there and you're waiting, and I'm sure we've all been there, the longer you wait, the more concerned you become. When someone comes out and says, we need additional tests, does it mean that you have cancer? That's what I thought when I had a mammogram, and then they wanted me to have a needle core biopsy and sweating bullets thinking that I've got cancer.
I think it's difficult, but the vast majority is because they need a better look. What we want to see in the best mammogram, you want to see all the way back to the chest wall, you want to see all the way down to all the lymph nodes, and you want to have a good look at that. If the breast tissue, sometimes it might turn a little bit on itself, you might not get that whole view, then they're going to want to have a better picture. And so they'll ask you. If there is any question about what they're seeing, they might want tissue. The tissue really is a better example of what's happening, and so looking under the microscope might be a better way of doing it. But I think the important thing to think about is the vast majority of those comebacks and the vast majority of those are not going to be cancer. The statistics, we always talk about statistics, 8 out of 10 lumps are not going to be cancer, and then the vast majority of callbacks are going to be for better looks.
If you're trying to get the breast as flat as a pancake so you can see through it, should I be asking for a 2D, a 3D mammogram? Does it really make a difference?
Actually, they did recently come out with data that shows that 3D mammography is the best at detecting breast cancer. And it's interesting.
Do I have to ask for that, or do I expect my mammographer or the radiologist to suggest it?
You should ask, because not all places. So Howard has just gotten 3D mammography, which is important because in looking at disparities, that's one of the things that was looked at, that our communities don't have 3D mammography like some, and is that one of the reasons why we're having later pickups of breast cancer? So, trying to address, making sure that all patients get the best treatment is helping chip away at the disparities. But yes, 3D is what you should ask for. Don't assume that you have it.
And 3D is better than 2D, so just go right for the higher number.
Absolutely.
We're talking all around inequities, so let's get right to inequities. I saw this report not too long ago by by the Journal of American College of Radiology this summer, found that race to be the pronounced driver of delays in screening and treatment. Your thought on that idea, and what are some of the factors that continue to contribute to health disparities?
So with health, and that's when we talk about health disparities, we want to talk about the ways that we can improve it. But race is not the only thing. It is a huge factor. But race, socioeconomic status, there are ethnic differences, religious reasons why there might be inequities, and in a lot of minority communities, in particular in the Black communities, sometimes there's a distrust of the medical field in general. And so those are all things that together combined will really lead toward those inequities. So when we really are trying to address how do we improve this, we have to improve access. We have to improve the access to health care. We also, which some of that actually happens with things like the Affordable Care Act, being DMV or the Washington, D.C. area is a perfect example. There are parts of D.C. that are very underserved and that don't have the facilities for you to go and walk in and get a mammogram. And Howard does a great job of trying to position places throughout the community to do that, but making sure that the communities actually have the appropriate things like 3D or or at least 2D. And then also just making sure that the quality of care is there. We always talk about access to care, but it really does come down to quality of care. And I think that's what Dr. Wilson was touching on, is that it's not just being able to go in and see a physician. It needs to be a physician who understands, what maybe some of your hesitations are, understands what some of your if you lack certain resources, so that they can work with you in order to kind of break down those inequities and make sure that you're getting the proper care that you need. So that's some of the ways that it contributes, I think, for sure.
There were some personal barriers that I hadn't thought about, and you were talking about access to care, actually getting there. Transportation, and the cost of parking, the cost of getting a taxi if you have to take a service like Lyft, and how do we get around things like that? Are there American Cancer Society helps or anything like that you can recommend to our viewers?
Well, within the communities, especially underserved communities, you do have a lot of outreach, and so sometimes resources can be made available to you to help with transportation, to help with child care when you come in for your mammogram. And you can do that here as well. So a lot of women have to make the choice. Do I go to work? Do I keep my kid? What do I do? And so oftentimes we're faced with challenges that others or majorities are not. Right. But there can be resources, but we just have to know what your needs are, and then we can try to help you find the resources.
Communication is key between you and your provider.
It absolutely is. And then having the network within the institution, we're blessed to have patient navigators. And so that's someone in your organization that is tagged to hold the hand of the person there. That American Cancer Society, we know that there absolutely are other organizations out there that some health insurances will pay for ride share. There's some ride share companies out there that will actually also provide support. So it really is about making sure that you're plugged in. But that's the difficult part, right? Yeah. How do you get plugged in? How do you know? I mean, if you're working, I think about, we were all day long. We've been working from 6 a.m. to right now. I probably haven't had more than 5 minutes to think about something for myself. So it's really about trying to make sure that you're connected but it's hard. And Black women are disproportionately held to head of household responsibilities. And so oftentimes it's not just you you're thinking of, right? You're thinking of you, your family, how do you get it done? How does everything happen? And so those decisions are oftentimes made with all these other things that you have to factor in.
And again, COVID doesn't make it any easier
No, it
because the same woman who is trying to negotiate a job, childcare, and whatever is now fearful of going into the workforce because of a disease that she might bring back home to her family. So it doesn't make things any easier.
You know, you speak about fear. One other thing that I think, you know, and I have patients talk about sometimes women don't come in because they're afraid that they're going to get a diagnosis.
Oh, yes.
And so they kind of avoid it, and especially if you are a head of household, or if you're functioning at head of household in a lot of ways. You know you have to go to work. I can't go in because if there's something's positive and I have to do a biopsy, then I'm going to miss more work, and then I'm going to do these. And so a lot of people are fearful just of getting a diagnosis. And so I think it's important to reiterate again, and I think Sara said it early on, the earlier that it's detected, the more treatment options that are available. So I think we all have that fear. You know I do personally. Anytime, I mean, I'm probably the worst hypochondriac of all. I mean, I think I feel one thing and I'm like, oh my gosh, I'm dying. And you know, and it's not necessarily the case, but you just want to make sure that you're getting everything checked out and kind of face that fear head on. You've got people here. We're always going to be here to be supportive. And I think especially for Black women, we take on so many responsibilities and we put everybody else, you know, in front of our own self, you know, our own well-being, that sometimes we have to stop and take a beat and say, okay, today I'm going to take care of me, and maybe make it a healthcare day and say I'm going to go get my. As Black women, we don't do, because we're worried so much about taking care of everybody else.
Exactly. Put yourself first so that you can take care of everybody else in your family. Again, with inequities, this was another study that came out recently. Boston University Sloan Epidemiology Center has developed a new breast cancer risk prediction model specifically for Black women, suitable for use in primary care. How are these kinds of risk models used, and why are we just getting one specifically for Black women and women of color? What does it mean as far as treatment and diagnosis?
So this is important, and this was a wonderful article that was just published, because we know that after 20 years of being in oncology, we all know that most of the studies, the clinical risk models that were developed, that we talk to a woman about and we say, if you have this, then your risk of breast cancer is higher or lower, was based on studies that didn't include Black women. And so what we found was, as we were using these models, we were finding that we still had more Black women who were being to take therapy to prevent breast cancer. Like some women who have a higher risk of breast cancer may take tamoxifen, which is a medicine that cuts their risk of breast cancer, developing breast cancer, by 50%. That was a study that was done in 2000, and I was a fellow then, and I remember working on that, the STAR study, and we were sitting there by the phones, and we're calling women, and we're getting their information. And I remember filling one out, and they asked for race and things like when your menstrual cycle started, how many children you had, all the things that may affect your risk of breast cancer. And I changed race on it once, and it changed the risk to low risk from a high risk.
From a person of color to majority race?
Just by that, this risk model is not appropriate for all women. And there were a lot of, even Howard came out with, developed a risk model that they were thinking was more appropriate for Black women. But what we know now is that, you know, there isn't a Black breast cancer. You know, race does not determine the type of breast cancer you have. But there may be things about cancer. So just like some populations have more this or that, blue eyes or green eyes, well, maybe we have more of a certain genetic preponderance of, and that's where we need to be in terms of looking at the breast cancer, and not even looking at breast cancer, but looking at your risk for breast cancer. And so there is now a study, it's been open for a while, should be used with Black women by primary care doctors, and if you're a Black woman who's listening to this, you should make sure that when you're talking to your doctor, you make them aware that there is this new risk model. And they're looking at that along with all these other factors that are more appropriate for all women, not just Black women and white women. And they're going to hopefully come up with a model that's very specific to women in terms of when you start your more specific, based on biology, I think is going to be one of the things that's going to help us, again, start to chip away at this disparity.
Sounds like we need to be part of clinical trials.
Oh, absolutely.
So why aren't we more into clinical trials?
Part of it is, there is a fallacy that Black people don't want to be in clinical trials, okay? And I say it's a fallacy because there have been studies that have shown that a Black person is just as likely, probably more likely, to say yes if asked to be in a study. So that's
The main thing is being asked to be in the study.
Asked to be in the study, because I think people are still holding on to the Tuskegee experiment in terms of assuming that Black people don't trust medical science and in terms of experimenting or, quote, being a guinea pig.
Right.
You will hear that, but the vast majority of patients of color, if asked. And so I think there are assumptions. Number one, there are assumptions that someone might not want to be in a study, so they won't be asked. We have to have the clinical trials in the institutions that see these patients, because if you're dealing with, as you were talking about, all the restrictions people have, time, money, being in a clinical trial gets you the best care, the latest technology and drugs, but it is time consuming. You're seen by your doctor to you. But all of these things are being done to try to get more of our women in clinical trials, because the only way we'll know if something is going to be appropriate for us, just like we knew that this risk model was not appropriate for Black women, is to be a part of the study.
I always loved the Copenhagen studies that were done, and that's a homogeneous group of women, but it was information that was supposed to be applied to all women. So we need to be involved in these clinical trials to get answers for us. Going back to the Basics 101, we have some questions that women have asked, and this is one that I phrased: when it comes to pap smears, no longer necessary after age 65 if all your recent smears and exams are normal. Is there an age at which you do no longer need a mammogram?
So,
Somebody out there said yes.
I think that there is probably going to be some differences in the ways that people look and answer that question. For me, as someone who sees a plethora of women across age groups, but there are things that you can absolutely incorporate. I typically think about those women who are coming to my office, they're 80, they're playing tennis, they're taking care of their own well-being, they're running their own household, they have grandchildren in their home, and they're doing all of these things on their own. And so there are some ways of sort of stratifying those patients and looking at them as being less fragile and better health, stable. And those patients, I think, as long as they would do something, if we found something, I offer mammography to those patients. For those patients that are less, or who are more fragile and are less healthy and would not select to do anything, then we probably, I have a thorough discussion of what that really means. And they may not be a group that we will screen. There are some thoughts also about where some of these studies ended age-wise, and I think that when we think about age 70, we think about that as being some of the limits, but 70 is young.
It's the new 50.
Exactly. And so, so if those patients are,
I hope it's the new 50.
right? Those patients are well and they're well cared for, and they're having great relationships with their primary care physicians, and they're doing all of their wellness things, and it's working for them, then I think they should be screened and they should have a voice. That's the thing. Paternalistic medicine has never worked for me. Discussion, collaboration, making sure that you are being you're listening to your patient and being a part and helping them design what it is that they're looking for.
You're all part of the team, not just the team that comes in and talks to you, but you as the patient is an integral part of that. And you have to listen as team leaders.
Yes.
And help
Educate
them to educate patients, to bring that information to them so they can make the best, most well-informed decisions for themselves. There may not be decisions that I would make for myself, but that doesn't mean that that's not the most appropriate decision for my patient.
And
We're
you often-
talking, go ahead.
And you often have to advocate for them as well, because I think a lot of times when you ask that question specifically about age, because a lot of people get hung up on age, and I think a lot of times you'll read 75, don't get a mammogram after 75. And a lot of times as physicians or just as healthcare providers, we really have to advocate for our patients, because sometimes the insurance company will also say, okay, well, they're over this age, and so we're not going to cover a mammogram. So when we start talking about inequities and advocating for patients, a lot of times we have to look beyond, when we talk about access, I think that's a general term, but sometimes we have to go really back into the minutia and start working with the insurance companies to say, okay, these patients are different, or this patient needs to be an exception. When we talk about research and getting people involved in studies, sometimes it's the way we put the study out. If the only advertisement is online, you've knocked out a whole portion of the community already. So a lot of what we have to do when we talk about inequities is not that information. It may be that sometimes we have to go door to door. It may be that sometimes we have to send out mailers. I'm a technology person just as much as the rest. When something goes down and someone hands me a piece of paper, I freak out. I'm like, what is this? But sometimes we have to do that. And I think particularly in instances like screening, it's so important to really stress to patients that don't let your age be the deterrent, because if you are functional and you have a great, what we call performance status, if you're doing all these things, then you need to, and you want to get treated, then let us help you to do that, because we are probably going to have to advocate for you and with the insurance company.
The trusted messenger. I remember that I covered a story here at Howard, and they had ambassadors, people in the community going out and talking to their fellow residents, and that was the ultimate buddy system.
And another thing too, just to piggyback on it, we're putting a lot on the patient, right? But the physicians, we have to do a better job at educating physicians who aren't cancer care providers.
Absolutely.
As cancer care providers, we think we know what needs to be done, and that's what we do. But a lot of primary care physicians or physicians who just don't work with cancer, they don't do the screening necessarily the way it should be, and they follow, oh, you're 70, 65, you don't need this anymore. So we really have to educate people.
Or for instance, one of the things that I think is important to look at are statistics that we see. The age 40 to 50, there are some guidelines out there that say that you may not start at age 40, maybe you should start at age 50. But when you look at that age group between 40 and 50, they have the highest mortality rate for Black women. So for me, that doesn't make sense to have my patients start at age 50 when you could potentially lose all of these women who are in the prime of their lives to having a diagnosis that they may not find too much later because they're not being screened. We know, and we've seen the data, is that if you are not being screened, the likelihood of feeling something is much larger than the likelihood of seeing something on mammography, and likely puts you into stage 2, because that's 2 centimeters is usually where we start to feel things, and that puts you in the beginning of stage 2, when in actuality what we want is stage 0, stage 1 for the best possible statistics.
How long has the cancer been growing for you to feel something in a breast self-exam?
Oh wow! So if we're talking about, we usually say that. That breast cancer is slow growing. I'm not quite sure that that's the case, but it's usually been there for many years. We think of somewhere between 2 and 10 years, depending upon what literature you read.
Jackie, you were talking about doing the breast self-exam. When should I start a breast self-exam?
Typically, we recommend the same time you would start mammograms, so in your 40s, unless you fall into a higher risk category, because one of the problems that we have, especially as Black women, we have cystic breasts. So it gets very confusing when you feel a lump or you have pain, is, what is that? So typically at 40, and this is what most of the organizations, if you look at the American Cancer Society guidelines or the U.S. Task Force guidelines, if you're going to do breast exams, they say in the 40s.
Breast self-exam.
Breast exam, even that, I personally think 25, 30,
Yeah.
because we see it so much younger.
Yeah.
And again, when we're seeing it younger, they're coming in with more advanced. So if they start feeling their breasts at the age of 25, get comfortable with your breast, learn how to do a good breast exam. If you feel something you're not sure about, go see your doctor, right? And again, part of the thing is doctors don't think 20, 25-year-old patients are going to have breast cancer, right? But if it's something that persists, don't ever take no. You get to know your body, and if someone tells you no, 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 it's nothing, go someplace else.
You're
All
saying
right?
20 to 25. We have seen the stories on TV, they are rare, where the 15-year-old has found a cancer through breast self, being able to detect at 25 something that's
I think it's probably more about getting to know your body. There is this wonderful website that's called Know Your Girls, and it's a great double entendre. Of course, it's a little risque, but it really is about learning what your body is. And so right now we are thinking more about, it's more important to know what do your breasts feel like?
Yes.
What does it feel like each month after you have your period? And so those are more of the things that we want to have patients do to educate themselves. Because you know your body better than anyone else. And if you find something that just doesn't feel right, then that threshold for me is low enough to come see me. I love celebrating with patients saying, it's okay, we found nothing.
All right, you found something and you're having treatment. We want to talk about the different areas of treatment. Obviously, surgery is what everyone thinks of.
Surgery is what everyone thinks of, but we know it's no longer surgery. It's a team approach. You may start off with your surgeon. However, a good approach to breast cancer is making sure that everyone on the team has purpose and that everyone on the team is adding their expertise to the patient's care. So for me, I would start off with the surgeon. I might give some guidelines to what's going to happen next, what we're going to do, how we're going to biopsy. But then I always share that it's a team approach. You're going to see your medical oncologist, you're going to see your radiation oncologist, you're going to see if we need to have a plastic surgeon, you're going to see all of them as your experts on your team, because it's important for you to hear from their mouths what they think is most important for you. And so I think that anyone who's trying to get you to just see one clinician and sort of get you out the door, then that may not be the best team for you.
Is
Right.
chemotherapy the way to go after surgery for everyone?
Not for everyone. And that's the importance of what Lori just said, seeing several people, seeing all the people on a team. Because there have been times when I've seen a patient later and they were told they just saw their surgeon, they just had the lump removed, but it was but they never saw the medical oncologist because they were told, oh, we caught it early, let's remove it. And they said, you're cured. So I always talk to anyone who has cancer and say, have you seen your medical oncologist? And not just because I'm a medical oncologist, but there are times when that one physician may not know what the other physician may say. And the same with me. There are times when I might think that this patient may not need radiation therapy, but I still will send them to Jackie, and then Jackie will, because she's the expert, will make that decision, and sometimes I'm wrong. But I never say to the patient, outside of my purview, my expertise. But to answer your question, not everybody needs chemotherapy. Chemotherapy is considered systemic therapy. So when we think about cancer, we think about two general types of treatments. Local treatment, meaning the treatment that just affects right where it's done. Surgery is local treatment, it takes it out, but it doesn't affect the rest of your body. Radiation therapy is local, it treats where it's aimed, but chemotherapy, and I say chemotherapy broadly because nowadays chemotherapy comes in an IV form. We have pills that are chemotherapy, or we call it hormonal therapy. We have IV immunotherapy, which is the newest type of treatment we hear about, which is like chemotherapy in that it's given IV most of the time, but it's actually not going straight to the cancer cells to kill them. It's revving up your immune system so that you can help kill these cells on your own, the way that our body should be doing. And so now that we have all these different types of treatment, two things determine whether you need them. One, the stage, and that means how likely the cancer is going to may come back, because the chemotherapy, even though you may have your cancer removed and your doctor says it's all gone, and you're thinking, okay, I have no cancer, so why do they want me to take this medicine that may make my hair fall out and make me sick? Well, it's because we know that based on the stage, that potentially there is a chance it could come back. And sometimes there's like a 70% chance it could come back, depending on the stage. Like if you have a stage 3, and that's in 5 to 10 years. And we know that giving some type of chemotherapy, usually it's for anywhere from 3 or 4 months, but not every day. It's once every 2 weeks, once every 3 weeks for a period of time, helps to reduce that risk by 50%. So depending on the type of cancer it is and the type of chemotherapy you may be offered, it can make a significant impact on whether the cancer comes back. And there's all kinds of models now. We're looking at a genetic DNA level, things on the cells that might help us determine whether this is coming back. There's tests like you might have heard of, something called the Oncotype DX, where they have a gene panel that they test the cancer cell for, and it gives you a risk score, a high risk, an intermediate, or a low. And that helps your doctor know, based on the biology of that cell, not just because you're this age and you had your period, but because of that cell, how likely you are going to have a reduction in the risk of it coming back if you're giving chemotherapy. If it's low chance, it tells you giving you chemotherapy is not going to make a difference. You don't need it.
Well, that was an amazing test when that came out as a predictor for what your future was going to be.
Absolutely.
We've talked about chemotherapy, and you mentioned radiation. So when is radiation appropriate?
So it depends again on the stage of the disease, and there are different types of radiation that we can do. Some are implantable devices that you will get over a short period of time, and again that depends on the size of your tumor, the indicators of the tumor itself. Or radiation can be external beam, like on an x-ray machine, and a course of external beam radiation for breast cancer can last anywhere from 4 to 6 weeks. But the point is what Dr. Wilson was saying, we work as a team. All right, so as that team, typically we will talk about, once you've been diagnosed, we get together, we have a tumor board where we'll present your case, we'll look at your imaging studies, we look at the actual biopsy, the pathology, if you've already had your definitive surgery, but typically we even talk before you've had your definitive surgery, and we come up with a game plan, what we think may be the best way to approach your care, and then when we meet with you, we're able to share this information with you. So before you even start, we already know what the treatment is going to entail, and we make sure you see everyone that you're supposed to see, including the plastic surgeon. So we really try to personalize your care, and that's the best way to treat breast cancer. It should be personalized, and you have to look at the individual and the individual's cancer, because it shouldn't be a cookbook, you know, where this is what you do, because that's not how it is. So there are different types of radiation, and no, everyone doesn't need radiation. Again, it depends on the stage and what we're trying to achieve.
You talked about plastic surgery. We have come definitely a long way when it comes to plastic surgery, but people are afraid to deal with a breast cancer diagnosis for fear that they're going to lose their breast. Personally, I had a benign cyst when I was a teenager, and they told my parents if they see something, they'll take the breast. So when I woke up, I had no idea whether I would still have a breast or not. We've definitely come pretty far from that. Talk about the fear and breast cancer, breast reconstruction option.
A team approach. You know, when we talk about surgery, you know, Lori and I work hand in hand in the operating room to do that. But really it is a team approach, because one thing that we didn't touch on is sometimes chemotherapy comes first. You know, a lot of times people say, oh, go to surgery, but sometimes the tumor needs to be treated beforehand. So that's why if you are seeing people and you feel like maybe you're not getting all the information, don't be afraid to speak up and say, hey, I want to see a medical oncologist, I want to see the radiation oncologist, I want to see the plastic surgeon, or however, ask for whatever team member you need to see, because it's not always cookbook, and sometimes we start in a different order. When it comes to plastic surgery and reconstruction, I like to see as many patients as I possibly can, because a lot of people and a lot of other practitioners that are not cancer doctors will think that if you're only getting the mass removed, or what we call a lumpectomy, if you're only getting a lumpectomy, then you don't need to see a plastic surgeon. But sometimes, depending on your breast size, if you take out the size of a walnut but you're only an A cup, that's going to make your breast look really, really different. And so it's important that you have the opportunity to speak with a plastic surgeon, because there are things that we can do, even if you're not removing the entire breast. There's things that we can do. You might be able to rearrange the tissue, get a breast lift. Sometimes we can do things, we can do a reduction on one side to match where the tumor's been removed from the other side. So it's not just when you have the whole breast removed. We even do reconstruction when it's partial breast removal. When we do remove the whole breast, we have all kinds of options. We can do what we call implant-based reconstruction, which means that we'll reconstruct the breast using either a saline or a silicone implant. We can do what we call autologous tissue reconstruction, which is basically we use tissue from another part of your body to create the breast. And they all have different advantages, different disadvantages. It's quite a conversation. At times it can be overwhelming, so I typically will meet with people on multiple occasions to go over all of that. And what I do tell people is that reconstruction can happen at any time during the process. So if you're someone that's out there now that's already had their breast removed and no one offered reconstruction, I can still help you, or a plastic surgeon can still help you. We can do what we call delayed breast reconstruction. We can do it at the time of the mastectomy or at the time of the lumpectomy, but we can also do it later. So I think probably the biggest message, the most important message with reconstruction, is that it can be done at any point in the process. You can have gone 10 years with no reconstruction and decide, you know what, I'd like to have some girls, I'd like to have some breasts, or I'd like to look a little bit better. And you can do the reconstruction at that time. If reconstruction is not for you, we have prostheses. So there's so many options that we can do. And the other key point that I think we don't talk about a lot is a lot of people think reconstruction is not covered. A lot of people think, well, I didn't get reconstruction because it's not covered. My insurance won't actually pay for that. My insurance is not going to pay for me to get an implant. And that's untrue. Reconstruction is actually a part of the continuum of breast cancer care. So if you have insurance, your insurance should cover the reconstructive process, whether it's done at the time of the initial surgery or if it's done 20 years later. So if you're someone who, again, wasn't offered breast reconstruction, it's never too late. Or even if you're going through the process and you're saying, well, my doctor's telling me I'm only going to have the lump removed, so that's why they're not recommending I see a plastic surgeon. If you're just not sure, ask to see a plastic surgeon, and we can talk to you about all those options, because they're plentiful. There's a lot of options. We can do a lot of things that's really great and really restore the breast, that stigmatic, those stigmatic incisions and scars and things that people always associated with breast cancer before. We've come so far. We have plenty of breast cancer patients who look just like a patient who's had a breast reduction or a breast lift. No one would ever even know that you've had breast cancer. So I think it's important to know that those options are available and that it can be done at any point through your treatment.
Seems like you should come to your doctor with a notepad and a pen and pencil with
Absolutely.
all the questions written down so
Absolutely.
you can have all the answers.
And bring someone with you.
Exactly.
Right. Bring someone with you.
Yeah.
Exactly.
Ask questions,
Yes.
ask questions.
And then again, with Dr. Bolden and I, we have to work closely together
Very.
because radiation and plastic surgery may not necessarily go well together, but we coordinate this care so we know who's doing what. So that's really important about having a team approach. So everyone knows.
But it may be at the time.
It's
you
the
get it.
timing, right.
And it's so important because the timing, I've seen patients that have had the most beautiful reconstructions, and then the order that it's done in, it makes it so that then they get other treatments, and then the reconstruction actually gets treated, for lack of a better word, and it doesn't really look like it did when they actually had the reconstruction. So understanding the timing and having your ambassador, your advocate, and the physician to be able to help you to navigate that and say, okay, here are the steps that we take first. And then also understanding that reconstruction in particular, I tell most patients that even if I do your reconstruction immediately, I tell patients anticipate that it's going to be multiple stages. We don't solve the problem right at once. A lot of times we have to do multiple procedures. Doesn't mean that you're going to be in the hospital. A lot of the procedures that I do are outpatient to do reconstruction, so you're not always coming in the hospital, you're not always staying for nights and nights and nights. Oftentimes you're coming in and going home the same day, or maybe you may have an overnight stay. But there's so many different options, and we can really cater what we do to your specific circumstance, because everybody's different. And so it's a designer approach for every patient. I think the whole process really is a designer approach. What kind of chemotherapy, whether you have radiation, what type of radiation, what type of surgery, where are your incisions going to be when you do surgery, all those kind of things. It's very much a designer approach that's specific to each patient.
Are you finding that patients are Googling first and then coming to you?
It's a mixed bag, and that can be a blessing and a curse, because sometimes patients come and they've Googled and I'm like, oh God, and you
have to un-Google.
You have to un-Google a little bit. Yeah, you have to un-Google. Or WebMD has been
yes, that one. Yes.
That one can be.
I've seen a commercial on television, and maybe some of you have heard it out there. Keytruda. Is that the new thing in drug therapy? What's Keytruda?
Keytruda is an immunotherapy. Yes.
Okay.
So it is
triple negative?
For triple negative breast cancer. Okay. So it is the very first immunotherapy that's been FDA approved to treat in what we call the adjuvant or neoadjuvant setting, so in the curative setting. Immunotherapy, again, is this kind of new therapy. It's been around probably, let's see, when I was at the FDA, we were just starting to approve it around 2015. And it is one of the therapies that targets your immune system to help your own body kill cancer cells on top of with chemotherapy. Now, there are certain things about the tumor that we have to test for. We call it a biomarker to tell us if that therapy is going to be effective if it's used by itself. Okay, so Keytruda, and the other name for Keytruda is Pembrolizumab. That's kind of
Keytruda's easier.
Keytruda, yeah.
That's why we need the medical oncologist.
Right.
I have to remember both
fancy
names all the time. But Keytruda is, and now it's probably approved in probably in over 20 different uses now for different cancers.
Oh, okay.
So different drugs can work in all kinds of different cancers.
Because it's on TV every day, several times during the day. It's the miracle drug almost.
It is amazing. It's amazing because immunotherapy has a whole different set of side effects, much better tolerated for most people than chemotherapy. You don't have the hair loss. Not all chemotherapy you have alopecia or hair loss, but most of them you do. You tend not to have as much of the nausea and vomiting. There are some side effects of the class of drugs that can be very serious, though. So they're not benign drugs. They don't happen as often, but they can be very serious because it's your immune system. So you can have type of where you have like a pneumonitis, inflammatory conditions in certain parts of your body. But we're learning more and more about it. We know how to identify them and treat it with steroids, and most people get over it, and then we just keep treating. So
and keep hopefully succeeding with the treatments.
Yes. Now, in the breast cancer community is probably, if you're involved, you probably know about the withdrawal of one of those medications. I think it was last month or the month before. But, and it was, again, for triple negative breast cancer, where the FDA had approved this drug to be used in the metastatic setting. But because breast cancer is not quite as responsive to immune therapies as other cancers, like lung cancer, it was exciting that finally one of these drugs that everyone's talking about, it can be used with breast cancer. But they found when they finished the studies and another study similar that it didn't have the outcome that they thought. But right at that time, another immunotherapy had a wonderful result and is approved in that same setting. So in triple negative breast cancer. So it's there.
That's amazing too, because that's very difficult. We know how significant this is. Absolutely. All right, we've come through. We're survivors, we're thrivers, we're warriors. Yeah. Who do I see now as my doctor, a primary care physician or someone in the cancer community, medical oncologist, who is my doctor now, going forward with my health care?
So that also remains a team approach. I think one of the things that we think about is that treatment is done, you're done. Not true. One of the reasons, honestly, that I went into surgical oncology was for the relationships that continue after taking care of patients. And so typically in the first 2 years, we see patients every 3 months, and that's someone from the team, either the medical oncologist, the surgical oncologist, or the radiation oncologist. The 2 years after that, it's usually every 6 months, and then at year 5, usually it's at least once a year. So these are all at least time frames. Those are in your follow-up. When we think about those patients, though, one of the things that we know is that the primary care doctor should be a part of this. And so the transition of care should also be well communicated to the primary care doc, so that the primary care doc can also be a part of the team following these patients and doing that well. We haven't done that as well in our survivorship, but I know that that's one of the targets that we're working on.
Does the survivor still need mammograms?
Yes,
Oh, yes.
absolutely. Yes.
Yes.
You say it like, of course.
Yes. Of course.
But it's a
Yes.
question, because if you've taken something out, what's there to look for?
Well,
that is-
remember,
that- yeah, that is
the
good.
question
Right.
is, let's take a step back. If the vast majority of patients don't lose all of their breast tissue, 75% of women will retain their breast tissue. So our job and our goals are to provide the most appropriate treatment, of course, for patients. 75% of those will be breast conservation. So that means that they'll have breast tissue that needs to be surveilled. For those patients that don't have breast tissue that's left behind, then we don't typically provide mammography for those patients.
But it doesn't mean that they're not surveilled.
Right.
Yes.
So we would typically recommend for those patients that they do clinical exams. So they would come and we would do, clinical exam to see, because unfortunately you do sometimes have things that can occur after the breast is removed. It's rare, but we always want to survey.
And I think that is probably one of the biggest misnomers that is out there, that if you have a mastectomy, that your risk for breast cancer come back goes down to 0. It does
not
not.
true.
It's not.
Right.
Probably single digits, 2 to 4%, but it doesn't go to 0. So you still need someone to examine your chest wall. You need someone to talk to you about what's going on with your body and what's new and different.
One of
Right.
the-
Go ahead, I'm sorry.
Just very quick, one of the wonderful things is that we are having more people living after cancer.
Yes.
Right.
More and more, and living long time. And so it does become very important for primary care docs to kind of be aware of what type of surveillance you should do. Usually there is a transition to the primary care physician after year 5. There are some cancers that because you've had that cancer or because you've had a certain type of treatment, you might be at risk for cancers in the future. And so those are the type of things that we try to convey to the primary care docs in our notes and things like that.
You don't just drop the patient and move on.
Exactly.
The team approach continues. This portion of the wrap-up is the breast cancer personal action plan. And the question is, what are some of the main actions women can take to empower themselves against breast cancer? That's for everybody on the panel.
Start.
So I think
And then we looked to the left.
well, I think one of the most important things is to have open discussions with your primary care physician, making sure that you get your questions answered. Empowerment is something we talk about, but it's hard. It's hard to be empowered for yourself. And so having someone with you, if you have something that's new or different, is oftentimes an important part of your survivorship.
So you can't necessarily prevent breast cancer, okay? But you can detect it early, right? So I think that's one of the key things that we've been driving home today. Make sure, so this is just in general, this isn't just about survivorship, but in terms of decreasing the likelihood, breast cancer can be genetic, It doesn't have to be, all right? We can't say what necessarily causes breast cancer. If we knew what caused it all the time, then you wouldn't have it, because we could take it away. But again, that's where the screening comes in and knowing your body. So make sure you get screened early, and just in general, have a healthy lifestyle, right? Don't drink in excess, don't eat in excess. Make sure you're healthy, exercise, get a well-balanced diet, get your screening. So these are the kind of things that we can do, and early detection is really the best way to cure you.
Right, and these are risk factors for all cancers that we can control ourselves, empowering women.
I just echo a lot of what both Jackie and Lori just said. One is just to talk about it, and I encourage people, I'm up at our family reunions and just talk about mammograms. You never can say it enough.
Family history.
Yeah.
Family history.
I
People
remember.
tell you about their family.
Yes,
Right,
talk,
right.
ask your, bring it up, make it kind of weird at the family reunion. Who had cancer? What cancer did you have? We'll
Well, the
ask
Surgeon
that.
General, it's family discussion day around the Thanksgiving table, not at the table, but during that season when people get together, let's talk about those things that we used to whisper about.
Absolutely. I was out on the streets in Southeast one day. I have a friend who has a health literacy grapevine. This is for Lisa Fitzpatrick. And we just go around and just talk to people. As the oncologist, I say, oh, you got questions about cancer? And this woman, she said, oh yeah, she was a vendor. She said, yeah, my mom had cancer. I said, oh, what kind? She's like, I don't know. And this was a young woman, and I said, was it breast? It could have been breast. And so it's just one of these things that I don't think we think about enough. Just encouraging people to talk about it. You never can talk about mammograms enough. I know that I've gone 2 years without having a mammogram, and my mother had breast cancer, and someone reminded me. You just have to keep telling people.
Someone had to remind you.
You had to remind me. A friend
life
said,
is so busy.
Be surprised.
Putting yourself first. You've all said try and put yourself first. So
Absolutely.
you now know on the 9th of every month you're supposed to do a breast self-exam and for the annual mammogram check-in.
Yes.
We're your buddies here,
Yes.
along with your mom.
That was the best idea, though, someone had. Remember, I think it was linked. You bring a buddy to.
Bring a buddy to the exam with
Just
you.
choose a friend, grab them and say, let's get our have you had your mammogram? My sister, it's like pulling teeth to get her to have that mammogram.
Wow.
Yeah.
Wow.
Sorry, Elise.
She's not listening.
I
She's
know
not
she's
listening.
listening.
Dr. Bolden, you have the final words.
So I think, and it's a bit of echoing, but I think taking ownership of your own health is so important, not just with breast cancer or breast health, but just in general. I think we can all probably relate to how many times I'm talking to a patient and I just ask them, okay, well, what medical problems do you have? What medications do you take? And you'd be shocked at how many people don't know what their medications are, what the dosage is, how many times they take it. They may be able to describe what it looks like. Sometimes they take it, sometimes they don't. So I think some of that comes to ownership, and we know it's really hard. We just like we said up here, I'm guilty. I'm guilty of the same thing. I know I need to get my mammogram. I was overdue, and so there's accountability that you have to do for yourself. But I think taking ownership, and then also again incorporating someone to help you. I think a lot of times leaning on your partner is really helpful. A lot of women, their breast cancer is detected by their partners. So I think also letting your partner in and leaning on your partner, and having that accountability as a buddy is also really helpful. And then also just ask, you deserve quality health care. Yes. Everyone deserves quality health care. So if you feel like you are not being treated as you should be treated, find someone else. I can guarantee you there's a team out there that will take care of you. Find someone else. Come see us.
Yeah.
We are more than happy to. We see patients all the time. We talk all the time. And so it's a group effort. It's a team effort. And just find someone else if you need to. Don't be afraid.
It's your body, take charge of it.
Yes.
Right.
That's it for us. I want to thank our Pink Power panel, Dr. Wilson, Dr. Dunmore Griffin, Dr. Horton, Dr. Bolden. Wonderful. I don't know if you were able to get your questions into the chat section and had answers, but if they're there, we will get back in touch with you because we want to communicate with you, because as you could hear from this panel, communication is key. The conversation you have with yourself to get to the doctor, to get that mammogram, to get that clinical exam, and then whatever the diagnosis is, the conversation you have with the medical team is crucial, and it could be a lifesaver. Thank you very much for listening to us. I'm now going to turn the program over to Cherie Spencer for closing remarks. Or someone else. Or Dr. Carla Williams, who first told me about that ambassador program, women talking to women in their own communities, making a difference, the trusted messenger. And she, Dr. Carla Williams, is one of the most trusted messengers Howard has. Good to see you.
Good to see you. Thank you so much. And I'm so grateful to be able to step in at the very end of this phenomenal event. And I always have the privilege as the Cancer Center's interim director to be able to give thanks. And I think that's such a blessed position to be in. I can't thank enough our fearless leader, Ms. Cherie Spencer, our Director for Community Programs, for conceptualizing and birthing this vision. Thank you, Cherie. And to the entire team of our staff, I see Ms. Vaughn there, I see Mrs. Higginbotham, Mrs. Gonzalez, and if I missed anyone, please forgive me, but thank you all for stepping up and helping in every way that you did to pull this off. I want to thank those who are in the room, and we have some of our special guests. I won't try to name everyone by name because I can't see everyone because I'm not used to the lights like Andrea is. But thank you all for being here. We invited some of our very special guests who have been our supporters over many, many years and collaborators, and we're so grateful for you. I will call two because I have a purpose for this. Or three. I think I saw Attorney Vanessa Gilliam Collier was here, and she's been one of our co-chairs for about 6 years, and she's taking pictures. Hello, Vanessa. And we appreciate her diligence and her commitment to this work. I see Thelma Jones, and I think Thelma just celebrated 11 years of the Thelma D. Jones Breast Cancer Foundation and her wonderful work here in DC. I see Grandworthy Matron Dingle from the Georgiana Thomas Grand Chapter Order of the Eastern Star, and I think we've had a 20-year relationship with them. And you can't see them in the room, but I know the Charmettes Incorporated are online on YouTube, and we've had a 40-year relationship with them. So I wanted to run the numbers because we are now approaching the Cancer Center's 50th anniversary. Wow. And we have been doing this work long before there were words for cancer disparities and cancer equity. We were doing this work because it's part of our founding mission. And as I've thought about this event throughout this past week, as we've approached it, the concept of legacy keeps coming through. I wasn't here earlier because I was actually doing our primary objective as a university and teaching our students. I had a class earlier, and trust me, they are grateful for you all because they got out an hour early so that I could come over here. But I've been thinking about that is our legacy, that next generation of students. That is why we're here. We are a university. We are a university that trains. And so what I thought about with this fierce, fabulous panel of women is that they represent the legacy. I think about our founders, our medical oncologist, Dr. Jackie White, and I see Dr. Horton standing on his shoulder, someone who had a vision for a cancer center at an HBCU where we could provide the kinds of care that you heard about tonight. I see Dr. Dunmore, and I think about Dr. Alfred Goldson, one of the pioneers of intraoperative radiation. And I know that she was trained and probably stood shoulder to shoulder with him. And of course, we can't mention breast cancer without thinking about the surgeons, Dr. LaSalle de la Fall, who has been inspirational to the work of Dr. Bolden and of course, Dr. Wilson. And so I mention this and I think about this legacy because when you walk into a room with these women, you may see them in front of you, but you have that pantheon around you of those giants who saw a vision and have brought it to pass. So know that you are in good hands with these women when you see them. And I just can't be thrilled enough when we look at this and know that it's all right here at Howard. And a lot of people can't say that. I'm so proud. So thank you all for everything that you've done. And in the interest of time, I won't go on and on because I could. But the woman in the center there, Miss Andrea Roane, I was running the numbers, and I don't know the number of years you've supported us, but every time we have called, you have answered. And you reminded us of the 9.
Yes.
Your years on WSA Channel 9, Buddy Check 9, the 9th of the month. Now we all have that back in memory, and we will carry that forward. And so we always say thank you with our little tokens of esteem, and we have a little token of esteem tonight to say thank you for your legacy. If you can make your way, because I'd like to hand this to you, if that's possible. Are you mic'd?
Yeah, but I can move. This way.
You're mobile? Okay, wonderful. I'll stand over here.
Semi-mobile. Shouldn't have done this, you know that.
Well, this is not that usual type of token, because we know you have so many accolades on your wall that you probably don't have any more room for, and I'd like to read it to you. It's not too fancy, but it's the thought that counts.
That's most important.
This is in commemoration of the 2022-2023 Andrea Roane Skehan Award in Health Journalism. In recognition of the contributions to the intersection of journalism and health, the Andrea Roane Skehan Award will be given to a deserving student who aspires to continue the tradition of exemplary Breast Cancer Awareness Month 2022, the year of our 50th anniversary, in recognition of our longstanding work in health disparities. The Roane Scholar, as we're calling it,
Oh my God.
will develop content in support of reducing breast cancer morbidity and mortality. This award will be in the amount of $1,000 to be awarded to a student that we will select in your honor.
Oh my goodness, that is the best tribute ever. Thank you so much, and I look forward to meeting that student when that time comes.
Oh, I think that student will look forward to meeting you.
Thank you very much. Thank you, Howard.
So thank you all again. Thank you to the panel. Thank you to our team here, our IT team. I want to shout out to Lush Events for this beautiful stagecraft. It looks great on YouTube. I was able to see it on my way over from class. Thank you all for being here. Thank you all for joining online. And we wish you well. We will share the link for those who were not able to log on live. And please share this information so that others have a great evening.
Thank you.
I know, for a second I was like, they left.